Good morning, everyone. Thank you, Professor Bruera, for accepting my invitation to deliver your talk. Everyone is eagerly waiting. And the topic which we have decided to discuss is what is the science behind integration of palliative care in continuum of care, because it is always very confusing how to handle these primary physicians and how we can integrate palliative care and what exactly the logic and science behind it. I think no one can explain us better than Dr. Bruera. We are very fortunate and I'm really thankful and grateful. It will be very difficult to introduce Dr. Bruera, but I will take 2 minutes and will try to introduce Professor Bruera. He's chair, many of us we know that he's chair of Department of Palliative, Rehabilitation and Integrative Medicine, the University of Texas, MD Anderson Cancer Center, USA. He is also chair of FT McGraw in the treatment of cancer. He has also the leadership roles with the WHO, the Multinational Association of Supportive Care in Cancer, and Iapc. Dr. Bruera's clinical interest lies in care of physical and psychological distress of patients and advanced cancer and support of their families. No one look after this part, and Dr. Bruera has a keen interest on this aspect. Dr. Bruera has established and led the Edmonton Regional and Palliative Care Program, the first 5 years of the operations, Department of Palliative Rehabilitation and Integrative Medicine at University of Texas, MD Anderson Cancer Centers. Many of us have visited and we have seen the most robust model of integration of palliative care. Numerous palliative care programs in Latin America, India, and different areas of Europe. Dr. Bruera has thousands of peer-reviewed publications, and we all have read your publication, Dr. Bruera. He has edited 31 books and delivered over 900 major invited lectures. He is recipient of several national and international awards like American Cancer Society Len and Edmonds Quality of Life Award and American Academy of Hospice and Palliative Medicine Lifetime Achievement Award. We are really fortunate to listen to Dr. Bruera today. And Dr. Bruera, thank you very much once again for accepting my request. Please go ahead. Thank you.
Thank you very much. I'm delighted to be here. This is a wonderful opportunity to share some time with colleagues from India. And I'd like to thank the Indian Association of Palliative Care. India is a country that my wife and I have learned to love deeply. We enjoy everything from India, your culture, your food, your colors, your art, and of course, very much so Bollywood. My wife has accepted that I watch everything that is where Amitabh Bachchan participates, and that has created no problem. She had a little bit more difficult with the fact that I also watch everything where Bebo, Kareena Kapoor participates, but she has come to also accept that aspect of my devotion to Bollywood, and therefore I would have loved to be present with you. It will happen another time. I had the chance to do that before, and at this time, this is the new way in which we can try to communicate. So the subject today is the integration, and this is a subject that is quite close to our heart, because it is the result of an evolution in our field. And basically, the way things have evolved has been the result of our understanding of the suffering of the patients. This patient had advanced carcinoma of the prostate. You can see that the patient has lost an awful lot of muscle mass and fat. He looks cachectic. He had asthenia, a lot of tiredness. He had depression, anxiety, and the beginning of dyspnea due to loss of muscles. And all those symptoms in this patient come together. Of course, pain is one of the most terrible symptoms, but many other symptoms happen together in a person who has cancer, but also in a patient who has AIDS, chronic heart failure, COPD, and many other clinical conditions that lead us to death. When the patient is ill, the family is ill. And this patient from Brazil was cared by a family that was going through physical suffering, financial suffering, and spiritual suffering. This movement, the new movement, started in the fringe. So it's a protest movement that started in the 60s in the suburb of London. People were taken away from hospitals because they were not really taken care of very well in those acute care hospitals when their disease could not be controlled well. And they were taken to places where they received impeccable attention to their personhood. In the meantime, mainstream medicine was building a lot of new specialties that are older than palliative care, like critical care medicine, emergency medicine, multiple other subspecialties. They're all about 10 years younger, including medical oncology is younger. But we were born out of wedlock, and therefore we had a much tougher time to make it into academic medicine as compared to all those other areas that were born within academic medicine. We have learned, and I think many of our colleagues understand and accept now, that the suffering of a patient expressed as the ESAS and the sensation of well-being is not just due to their cancer, their lung cancer, or their therapy. It also due to a number of emotional and personal things that contribute to the suffering, contribute to the symptom expression, and contribute to the medical procedures these patients go through. So that's personhood suffering. And our business is the alleviation of suffering that is universal in our patients as they are confronting an incurable illness. But a lot of aspects of that suffering are unnecessary and they can be resolved. We learn to establish priorities that range from the red, that are the problems that need immediate attention, so that you can focus on the ones that are more important, less acute, but more important, and they need the red and the orange to be addressed. And many of the suffering components of the green and the blue areas impact on the red and the orange and aggravate the expression. So we learned over time that palliative care is complex. The oncologists, the internists, the family doctors, they have tried to alleviate the suffering and were not successful. And therefore, an important definition is that what we do is quite complex and you need some time and training to do. That is what all these younger groups are trying to do. And so there are multiple dimensions of suffering. There are physical, psychological, social, spiritual, practical, end-of-life management, and even bereavement after the end of the death, in addition to the disease management. That is what specialists do so well. And so there are interprofessional teams going around that cancer patient. And those interprofessional teams, some of them have more red areas, that is, they're working more on the physical areas, but they're having different colors. They're also having to deal with the emotional in the case of the physicians, mostly with the emotional in the case of the psychologists, with the social, of course, the social workers, but also the case managers and the volunteers and the families. So the interprofessional team has a lot of overlap in our roles. And the domains have been very well defined, and we now know very well those little purple circles that are where we need to address, and we need the dimensions to address it. We started addressing it at the very end of life, days before death. Then we moved on when palliative care was involved in acute care facilities with bowel mount into days to weeks in palliative care units. Then we moved into the outpatient setting that we developed initially in Canada in the 80s into the outpatient palliative care weeks to months before death. And then we delved into the early palliative care. And of course, COVID brought us telemedicine, what we're doing right now, but not just for education, but also for treating patients that are suffering and their families. So there has been an evolution, and also the evidence has evolved from an emotion-based medicine, because it was the ethical thing, because it was the right thing to do, to experience-based medicine. This is what we are finding, to the randomized controlled trials that currently support the integration of palliative care. So if you look at the definitions in general, hospice care is close to the end of life. If you look at death as a breaking area, then you have palliative care that looks from the moment of advance, that means incurable disease. And then you have supportive care that covers a lot of those elements, but also covers earlier areas of the disease, as long as suffering of some sort is present there. And so that would be, in a sense, a time-based. The team is important. As you can see, this is a picture that was taken 3 or 4 months ago, but really this is the team we had in Edmonton when we started doing this in the late 80s. So early palliative care, integrated palliative care, has a longer history than people believe. We look at the ESAS that is done in multiple languages. It's done in many languages of India, including Hindi, but also Telugu and many other languages in India can use the ESAS. And we can measure the suffering of the patients. This tool and several others have been used to conduct randomized control trials. And there have been a large number of randomized control trials conducted since 2009 until now on the allocation of patients to a group receiving palliative care and a group receiving conventional care. And so I will guide you through some of the most relevant ones. In 2010, we had a very important one done by Jennifer Temmel, randomizing patients with advanced lung cancer to integrated palliative care early, within 12 weeks of the diagnosis of advanced disease, or routine cancer care by the oncologist. The measures were the ones we are describing: palliative quality of life, psychological distress, resource utilization. And what they found was better quality of life, better outcome index, lower depression and anxiety, less aggressive care near the end of life, and improved documentation of resuscitation. They found something that was not always reproduced after that. That is, the patients who received palliative care early survived more than the patients who received standard care. Now, the reality is the other studies that were done later did not show that difference. And this was a secondary outcome. This study was not designed to measure survival. It was designed to measure quality of life and symptoms and so on. But what is important to remark is not a single study has ever found that randomizing patients to palliative care resulted in any shorter survival. So that should be reassuring. Now, with regards to the understanding of their disease, in those who received early palliative care, the understanding was consistently superior to those who were randomized to standard care. And this is important because the understanding of end of life is what helps patients adjust much better and not receive unnecessary treatments. Of course, early palliative care patients had much more likely to be having accurate prognostic understanding and also to receive less aggressive therapy near the end of life. Camilla Zimmerman did a similar study, but with patients, instead of just lung, advanced cancer from multiple different primaries, randomized to palliative care by a specialist and follow-up or routine care. They used similar outcomes as the other studies I showed you, and they found that when you look at the p-values, significant improvement in the ESAS, quality of life, family distress questionnaire, and Marco Maltoni in Europe did the model of integrated palliative care. This study used physician only rather than a team or routine oncology care. The tools they used were reasonably similar, and they found significant improvement in a number of variables, anxiety and quality of life and chemotherapy use in the last 30 days of life and longer days in hospice. So a series of variables improved. Jennifer Temmel repeated the study in lung plus GI patients. Again, integrated versus routine care with similar outcome measures. And they found that there was a significant improvement, mostly in the lung group as compared to the GI. And probably that's simply because the lung group was having significantly worse symptom distress. And it's important to have symptom distress before if you want to measure a difference, because if there is not that much problem, then there's less to fix. When the problems get worse, then you are more able to fix them. But overall, when you look at the whole cohort, there was an improvement in psychological distress and quality of life in both groups that was mostly due to the lung group. When you look at the understanding of the patients, again, there was a significant improvement in overall understanding and discussion on end-of-life care wishes with the oncologist. Grudson did this study in inpatient. Now, they were looking at patients having an inpatient palliative care consultation. They were seen at the emergency room. They were randomized to an inpatient consultation versus routine care when the patients got admitted, and they looked at similar outcomes. Now, what they found was that there was better quality of life after 12 weeks, but a lot of the outcomes did not change very much. And the main reason for that is this one now was not so early, because these were patients who got admitted to the hospital. And so the survival of the patients was shorter. And also, overall, many of the bad things that could happen had already happened in terms of treatments that went on. So El Jawahiri did this study in patients who were being seen in the inpatient area receiving stem cell transplantation. These patients were coming from the procedure of stem cell, and they were again randomized to inpatient palliative care versus routine care, and they found better quality of life, better HADS, depression and anxiety, better ESAS. So depression, anxiety, and ESAS got significantly better in these groups. And they repeated the study in leukemia patients, again, in patients randomized to see the supportive and palliative care team versus routine oncology. And again, quality of life, depression, anxiety, and even less PTSD, post-traumatic stress disorder syndrome, was lower in the group that received supportive and palliative care. Gronvold and his team in Denmark did this randomized controlled trial of palliative care of variable intensity versus routine oncology care. And now you go into a study in which the intervention was less robust. A lot of patients had none in both groups, and many of the patients had only one intervention. In this study, they did not find much difference. And what that tells us is if the dose that you give, if the dose of supportive and palliative care is low, then you get a little bit of trouble finding differences. It's like the dose of chemotherapy being low. So the recent systematic reviews, these are systematic reviews, and this is the number of studies that were looked at. And there you can see that generally the quality of life is better. The symptoms are generally improved in several of the reviews, but they're not universal. And then survival generally is not improved. Contrary to the first study of Temel, survival is not affected. It's not better, not worse. What do we know? When there are interdisciplinary teams, there you see that when they're specialists, palliative care specialist driven ID teams, you see a lot of greens, a lot of improvement in many of the variables in these patients. As you move, as we said, into low dose of these, you don't see a lot of difference. When you see physicians alone, you have some greens, but not as many. And when you have nurses running the program, you have less green. And when you have, this is specially trained nurses, regular nurses, or primary palliative care, you see very little in the side of greens, suggesting that the best way to get those results is to get a specialist-driven interdisciplinary team. If you invest in doing these interventions with these type of teams, you get the difference in these variables. There are methodological challenges. As we said before, if the intervention is not robust enough, if you don't have enough expertise and intensity, the studies are negative. And also, if the intervention cannot be delivered, as we said, if you do one or two and then you cannot follow up, then the studies have a trend to be negative. But there are multiple methodological barriers that we have discussed. So what do we know so far? Early palliative care by specialist-driven teams reduces symptom burden, improves quality of life, improves or does not reduce survival, and saves money. When you give less chemo, you admit less people to ICU, you do less MRIs and molecular profiling that the patient does not need because it's close to end of life, you save a lot of money. What doesn't work? Very simple interventions done by one or few disciplines, mostly those are negative, and no evidence for the so-called primary palliative care. When I do it as part of my gastroenterology, cardiology, family medicine, oncology, there's unfortunately not much evidence that that type of practice makes a difference. And then single interventions have a trend to be negative. Why do patients perhaps live longer and feel better? Well, improved symptoms and function might increase adherence to more treatment. It might be that suffering kills and distress shortens life. And it might be also that palliative care spares the patients expensive therapies that end up shortening their life. What we know is that there is no reason to worry about shortening life. That is one of the areas that people are afraid. Now, how early are we getting those patients? We looked at 3,100 patients consecutively growing 10 to 20% per year. So our program was growing very nicely. And we found that the first consult to death time was 42 days. The oncologist knew that that patient was going to die 250 days. This is advanced care diagnosis to death. But we only saw the patient in the last 42. So there was a lot of opportunity for referrals that were not happening. And there you can see what happened over time. Our program was growing very nicely, but the time between first consult and death was not growing at all. Actually, it might be very short. So we decided to say, yeah, these are the Kaplan-Meier curves. You see, they're not living any longer. So we knew that solid tumors got referred earlier, 48 days before death. Leukemias and myeloma, 14 days before death. So very, very late. So what might be the problem? Could it be there's something related to the name? So we did a random survey of oncologists and advanced practice nurses with a very high response rate. And there you have the participants. And this is what we asked them. Would you refer a patient who's no longer receiving treatment for cancer to a service named, only we tell them the name, palliative care or named supportive care? More than 90% of them said, yes, of course, I would refer them to that service. But as you moved earlier in the disease, you can see that the number willing to refer to a service named palliative care starts to drop very dramatically. Less and less and less are willing to refer patients to a service named palliative as compared to a service named supportive care. When we asked them why, well, more significantly, they felt that palliative care, the name palliative care, was a barrier for them to refer patients. And they felt that hope, a decrease in hope in the patient, that they might Google palliative care and get hospice and death and so on, was a barrier for them. I'm talking for the oncologist to refer us, the patients. They all liked the services. Their median satisfaction was extremely high for what we did. Both the oncologists and the advanced practice nurses in oncology were very happy with what we did. We repeated this study 10 years later, and we found similar results, that when you look at patients no longer receiving therapy, they were likely to send them to palliative care or to supportive care, about the same percentage, a little bit more for supportive care. But as you move earlier in the trajectory of the illness, there was a dramatic difference in the likelihood that they were going to send them to a service named supportive care as compared to palliative care. And there you see for both groups, more than double likelihood to be referred. And of course, for both hematological and solid tumors, more for hematological, but for both diseases. And when we asked them if service was a barrier, big barrier, 36% felt that palliative care was a barrier versus 3% for supportive care. And decreased hope, almost 60% felt that the service named palliative care decreased hope versus 8% for supportive care. So people are worried about hope. And then we decided to look at 3 approaches to change their attitudes. One of them is goals of care or goals of CAR education. And we're going to go back to that in a moment. The second is an integrated model of care. And the third, of course, was the change in name. Simply, if they had so much problem with the name, the outpatient center and the mobile inpatient team were changed to supportive care. The goals of car is because everybody goes by car. Well, there's no public transportation in Texas. It doesn't exist. And therefore, you need to go by car. And therefore, what we say is when you buy a car, your goals for car are that you're going to go to places and you're going to have a great time. But if you take absolutely no precaution, you might get into all kinds of problems. And then if you take precautions, you might wear a seatbelt, you might lock your car, and then you do not have to change your goals. Your goals are the same, but you're taking precautions and making the trip safer and more agreeable. You do that with your car as a patient, as a doctor. And then when you have a cancer, you have goals, get cured, live longer, prolong my life. And you might do that and take absolutely no precautions, or you might take precautions by saying, if I get very ill, who's going to move and live with me? Who am I going to live with? Who's going to keep the home? Who's going to deliver my medications? Do I want to end up in the ICU or get mechanical ventilation? Those are the things that might go wrong, that by addressing them, you don't have to change the goals of your care. You just have to say, if things go bad, I have another plan. And that model, we taught that model to our oncologists, and they also started doing it with the patients. We also discussed the integrated model. If you try to do everything yourself, you're going to leave some blocks undealt with. If, on the other hand, you send consults to everybody in the hospital, you generate a congress practice that frequently ends up creating trouble rather than helping the patient because of so many people involved, not all of them agreeing on everything. And then when you look at the integrated model, they both work, the cancer treatment model plus the supportive care team work together, and they refer to other teams in a more cautious way by deciding together if these other teams should be asked to participate. When we changed the model and we did this teaching, we rapidly saw a 41% increase in referrals in 6 months. Not only an extended period between referral and death, patients started being referred earlier, but also many more patients were referred. And there you can see the changes in the Kaplan-Meier curves as the name was changed, and it happened very rapidly. You can see that from this moment, we had growth, usually single digits. From that moment of the name change on, the growth was always double digits, and it continued to be double digits for a very long period of time. And there you can see the growth as compared to the rest of MD Anderson. This is supportive and palliative care in blue. There you have in red the division of cancer medicine, and there you have the hospital as a whole year after year. You can see that year after year after year, we grew much more than the hospital. And in the COVID years, when other programs dropped, we did, and actually we grew, but because these are billings, and for the beginning of the pandemic, we did not bill, we actually grew about 5 or 6%, and the other ones dropped. And then we grew again this year as compared to the other ones. And the fiscal year just ended, but it's about 15% growth. And you can see that we've been gaining patients all the time. And there you can see the outpatients. The outpatients have been behind a lot of the growth of our program. Of course, that growth needs positions, and the red line is new positions hired, because you need to keep the number of encounters per year at a certain level where you can keep the quality of the care of the patients and prevent burnout among the professionals. It doesn't make any sense that you have this growth with the same number of doctors, because then you end up losing those doctors. You need to grow the consults, but you need to grow the consults with the growth of positions so that the number of visits per year remains below what we think is the top, that is anywhere between 1,200 and 1,400 encounters per year. When you keep around that level, there is limited or no burnout. If you go above that, as it happened this year, you start seeing a lot of burnout. You also need space, because the patients need to be seen more times. Before, the patients were seen 2.9 times and then they disappeared or died. Then by number 13, they're going to 7, 5, and now they're going beyond 7 visits with us before the end of life. So what is happening with early access in the United States? what you see here in gray and black are the so-called NCI comprehensive cancer centers. There are about 51 cancer centers that are big enough to have this side. And then there are 1,500 cancer centers that are non-NCI, smaller cancer centers, but 80% of Americans receive treatment in these non-NCI centers. When you look at the outpatient clinics, they are much higher in the NCI centers, but in the vast majority, they don't even have outpatient clinics. And therefore, you cannot reach patients early if you're not having clinics to see them. There's an improvement in a decade. This is 2009 and 2018. In a decade, there was a big improvement in the NCI ones. There was an improvement also in the non-NCIs, but still they're quite below. Palliative care units, quite bad in the United States. Even the comprehensive cancer centers don't have many palliative care units. Inpatient consultation teams, much better. There are, in the vast majority of the places, already inpatient teams. When you look at the number of clinic days per week, they're getting better. The NCI centers have it 5 days a week, and the non-NCI do not have much less. The number of days between the referral and death has doubled in the NCI cancer centers to about 6 months before death. In the non-NCI, from 41 to 84, so they're still quite behind in a decade, the number of days before death. But remember, these are the ones that are seen. A lot of them are not seen. And so perhaps something that worries us a lot is this. The NCI centers have developed palliative care fellowships. The majority of them have. The non-NCI have oncology fellowships, but very few palliative care fellowships. And with regards to mandatory rotation for oncologists, not even the NCI ones have enough mandatory 1 month rotation for oncologists. This is sad because that means that since the majority train in these centers, the majority of oncologists trained in the United States this year will not have had a rotation through palliative care. Research is in bad shape because the existence of the NCI centers is based on their obligation to do research. And if you look at that, less than 60% have even a structure for palliative care research. So what does this mean? It's much more available, but only 1 in 3 have an outpatient center, less than 1 in 4 a PCU, and barriers are financial with limited growth expectations. Are there criteria? Can you measure referral? Yes, there are criteria. We developed some criteria for when it would be appropriate that a patient be referred. And if you look at that, there are more patient suffering based, but there's some chronological criteria. And so these are needs-based, distress, and these are time-based. The majority of the ones where there was a very high agreement were patients who were having considerable suffering. And a small group, 2 of them, were related to time. But you can see if the patients gather these criteria. So 11 major criteria, 9 of the 11 are needs-based, 2, and institutions need to harmonize, and this is important. Wherever you work, you cannot define simply, we're going to set a bar and then send these patients, because if you don't have the resources, then you cannot see those patients. So it's important that we harmonize those resources well. And this is what the patients say. The patients want to be referred when their symptoms are not good. They don't want to be referred necessarily according to a chronological calendar. They want to be referred when they're feeling bad, and thus, or when their families are feeling bad. By the current referral, about 6 or 7 months before death, 72% of the patients feel that they've been referred just in time. 5 years ago, when they were referred much later, 80% of them felt that they were being referred too late. They are all happy with the care they're receiving. There's high level of satisfaction. The outpatient center is a structure that is very important. You don't need to have a waiting room. At MD Anderson, there's always a waiting room, and we try to keep it empty all the time because you try to avoid the patients to be sitting in front of each other with great levels of suffering. And so we try to keep them inside. We visit them inside the room where they have some privacy to discuss all these issues. We put the art on the ceilings where patients can see them, and we start the care at the moment they see the clerk. The clerk is a member of the team and needs to understand suffering, understand anger, understand those symptoms, have the team ready to be deployed, have places where hard conversations can take place, if possible, full beds instead of examining tables, plus inviting people to sit inside the room, do assessments that are tools that the nurses are well trained to do, and do them while the patient is waiting to be seen, the ESAs, the MDAS, the CAGE to see the risk for opioids, and a comprehensive nursing history. And then patients need to be able to phone us, and we need to be able to phone them. This is a nurse receiving phone calls, and this is a nurse actively phoning patients to how they're doing, because a lot of patients, although they have our number, they won't phone us. So counselors are important. More than half of the supportive care center patients receive visits from our counselors, and then the counselors can see them in person or they can see them in Zoom. And we did this long before COVID. About 3 years before COVID, we were already doing this type of telecounseling of our patients. Allowing patients to walk in is very important. The walk-ins with no appointment had less symptom control, were suffering more than the ones who came with appointment. And in other centers at MD Anderson, if you don't have an appointment, they won't see you. We see anybody who shows up. When COVID started, a lot of programs closed down, and we had the advantage of having had hurricanes. And during hurricanes, our supportive care center, because we had a center, we didn't close. We started phoning people from the hospital, the ones who were able to make it, and if not from our homes, we were phoning the patients and asking them how they were doing. If they needed prescriptions, we were phoning them to the pharmacies. And if they don't, we tell them, get your medication box. Let's look at what you have. Let's look at how we can give you medicines for the next 4 or 5 days until we can give you another prescription. When COVID came, we looked at the patients before, 4 weeks before COVID and 4 weeks after the declaration of the medical emergency. And what we learned is that instead of seeing less, we ended up seeing more patients during the 4 weeks after. This is a transitional week and than the 4 weeks periods before. Now, we looked at the characteristics of those visits. They rapidly dropped from being in person, 99.9%, to being telephone and video, with the vast majority of them. And this transition occurred with no sacrifice of doing the ESAs, the ECOG, the CAGE. All these measures ended up being doing by video and or by phone. The telephone over time dropped even more. Now it's very, very small percentage, but initially it was almost half was telephone. When you look at the speed of the change, it was very rapid. It was adopted very fast. If you look at the first week, already half had changed, then 4% and 2% ended up being in person. So there was a big drop, a very successful drop. And we learned that it is very important that we keep the care of these patients, especially when other cancer centers, specialty was closed. It helped us protect our patients, but also protect our clinicians. A lot of clinicians got ill in other programs, and it decreased our no-shows because, of course, we were reaching everybody, but also the walk-ins decreased because, of course, they were not walking in. Now, telemedicine will stay, and should we need national licenses so that people from one area can practice in long areas? We need to train our trainees in telemedicine because the etiquette is different and the care is different. We know that if patients are seen in the outpatient setting, virtually or in person, a lot of outcomes that are not nice are much better than when those patients are seen in the inpatient area. So if we are referred a patient as an outpatient, there's much more success in a lot of hospital outcomes as compared to being referred in the inpatient. So integration is here to stay. The level of integration can be looked and you can monitor it yourself. And it appears to be limited currently. There's not the level of integration that should happen. The dream is that a patient coming with a certain series of problems, if they see a doctor A, they will be referred to some programs. A doctor B might refer the patient with the same problems to other programs. Some doctors will refer them nowhere. And then finally, a doctor will send them to a supportive care center and the patient will receive a wonderful package of care. Out of 100 patients that receive the basic package of care, then the follow-up might need to be different for this young mom with cervix cancer as compared to this other older patient with end-of-life issues. And so the follow-up might not need to be the same, but the basic package of supportive care would be present for everybody being referred. The oncologist can refer to our team. Providing automatic criteria to the oncologist might be very helpful in helping the oncologist understand, wow, I was so focused on the lung cancer or the prostate cancer, and I wasn't aware that the patient had terrible symptoms or brain metastasis or high calcium, or the patient was going to go into a phase 1 clinical trial. This information is useful in helping me decide I'm going to send this patient. So there is a lot of unnecessary suffering, and it's unavoidable that some suffering will be there. But it's sad when we see that part of that unnecessary suffering is not relieved, and that happens when the referral takes a little bit too late, and then it's hard for the palliative care teams to be able to be as effective when the referrals happen very late in the trajectory of illness. So convincing our colleagues to send the patients early is wonderful. Early integration improves the clinical outcomes, reduces the cost of care, and it may even prolong survival. It should happen in the outpatient setting. That's the best place to send the patient. So the number of referrals as outpatients needs to be increasing every year. Each institution should decide the threshold. You cannot decide the threshold without understanding how many spaces you have. And for all of us working in this field, much better small, well done than large number bad. If they send you too many patients and you see them bad, then you are not making a difference in those that were sent to you or those who were not sent to you. While if you spend time and improve the ones that are sent to you, it will send a wonderful example, and then your executives and your authorities will allow more positions to allow an increased access to care. So that was my presentation, and at this point, I would love to hear comments or questions that any of you might have about this work in progress, that is the integration.
Thank you, Dr. Bruera. It was so good. It was so wonderful, and how beautifully you explained that package of care which a palliative care physician provides can improve quality of life and satisfaction. Arun, there are a lot of questions, Dr. Bruera. So Arun, I request Arun to go one by one the questions, and then Professor Bruera will answer.
Perfect.
Okay, thank you. So Dr. Bruera, we'll start with the first question. So the first question is the terms palliative care and supportive care. So the question is that the terminology is different and sometimes they're used interchangeably. So what are the practical differences when we talk about palliative care versus supportive care? Thank you.
Yes, thanks so much. Well, I think palliative care is our basic specialty. It's a medical specialty. Academic programs can be called palliative care. What we know is that to overcome the misperception of those who have to refer to us, and you might say patients are not so sure what is one, what is the other. Well, we need to remember that the patient's family can also Google and say, oh my goodness, what is this, what is that, and ask. But we need to remember that we will depend for all our careers on receiving referrals from others. And if the oncologist, the cardiologist, the gastroenterologist is afraid of sending us a patient too early because of the name palliative, and they think my patient is going to give up on getting their treatment, or they're going to talk to them about going to hospice and not getting treatment, or they're going to be afraid, then we got it. And so what we did is to say our academic department is a palliative care. Our inpatient unit for transition to end of life is the palliative care unit. But the areas where we want to get early referrals, the outpatients and the consult teams in the inpatient, we call them the supportive care center and the supportive care mobile team. And that helps reduce that fear that the clinicians have about referral, because if you tell somebody you're going to send to palliative care, the family might call you back, but if you tell them you're going to send them to supportive care and that's enhancing your quality of life and allowing you to function and so on, we are the specialists in palliative care. We will see that patient in supportive care. Our goals will be to help you be as functional as possible, but also to prepare for the transition. But it looks like it's much more accepted. So I think that I would say that there is some level of interchangeability, but I would propose that you take advantage of the name supportive, especially in the areas where you want to see this patient early. That is the outpatient center, and probably also your inpatient mobile teams. With regards to the unit or the academic aspects, palliative care is good enough. It's where I've worked all my life.
Thank you. That was wonderful, Dr. Bruera, and that answers a couple of more questions. So I'll skip one or two questions and go ahead. So one other question, we talked about integration in cancer centers, maybe in the bigger cancer centers. So what, in your experience, what was the experience about integration of palliative care in cancer care in not so big centers or maybe in the rural part of the country?
Well, integration, I would say the following. If you are offering a patient who has cancer, specialist care for the medical oncology aspect, and you put them in front of a medical oncologist, and radiation therapy under a radiation therapist, but you're not offering them any specialized care for their human suffering associated with this terrible illness, I think you're missing something. You're missing a part of the service. And so I would personally feel that the person who has access to a medical oncologist for an advanced cancer, if it is adjuvant therapy for breast cancer for 4 months, and then you're going to go into the community and your chance of death is almost very, very low. But if you get a patient with advanced cancer, it's going to see a medical oncologist and a radiation therapist, they should be able to see a palliative care specialist in that area, directly in person, virtually, or in another area where they are also seeing other patients with COPD or CHF if there is not enough volume of patients to be seen. So to me, it would be a little bit simplistic to say that because you live in a small area, you suffer less than a patient who is seen in Ames or in Tata or in any other center. The patient suffers the same, and suffering is very personal. If you get a lung cancer of 3 centimeters in the right upper lobe, the patient might feel tired, might feel sleepy, might lose appetite, and might get close to the end of life. If you just move that lump 1 inch higher, that same patient with the same diagnosis, the same prognosis, now has horrific brachial plexopathy, hemoptysis, dyspnea, and has a horrible physical death. But that same lung cancer of 3 centimeters, you put it in somebody who lives in a very good area and has servants and has extended family, and their suffering can be managed much easier than somebody who has limited support and limited home facilities. So putting that histology and that stage in the context of the human experience is complex. And so, there's no guarantee that because you live in a small area, you're going to get an easy cancer and you're going to get an easy family and social life. So I would say, to me, it's a challenge of delivery. And if you cannot do it, please do not feel bad. You cannot do it. It's not your responsibility to do it. It's the executives who need to allocate their resources. But I don't find that from an ethical perspective, you should not be offering access to specialist-driven palliative care to these patients, because it's very effective. And we need to convince academic medicine, and we need to convince leaders of hospitals that this is an ethical need. They accepted many years ago that you need a specialist for medical oncology. They accepted many years ago you need a specialist for radiation therapy. I cannot go there and say, Mrs. Smith, I'm going to take you to the cobalt unit and I'm going to give you a linear accelerator or cobalt. I'm going to give you 45 minutes. It needs to be a specialist. Well, for human suffering, there's complexity. It's not that simple. And so at least some of the encounters by a specialist make a lot of sense.
Yes, definitely. There is no other option for that. So, Dr. Bruera, the next one or two question sets are about non-cancer. So let me ask you the question and then feel free to answer the way you want to. So the question is, the participants have appreciated that the transition line from curative to palliative in non-cancer diseases might not be as easy as in cancer, which is well appreciated. And also the question touches on the point that what are the challenges and barriers of integration of palliative care in non-cancer diseases in your experience or in your opinion, please?
Yes, thank you very much. And that's an important point. I'll tell you one thing. There is confusion about the prognosis happening in all diseases all the time, because there are diseases like hepatitis C that was a deadly disease when I was working in this area, and even hepatitis B that was a deadly disease and even massive, and they're changing their natural history. And many of the cancers like disseminated melanoma, renal cell carcinoma, and small cell and non-small cell lung cancer, for which there was even no therapy 5 or 10 years ago. Now they can go with immunotherapy for a considerable period of time. I would say the palliative care doctors don't need to feel concerned about that. And with this concept of the ghost of CAR, you can incorporate your care in a blurred prognosis. Even if because remember, we're not fixing our time to a date. It's not because you're dying in 6 months that I'm going to see you. It's because you're suffering distressing symptoms, physical or emotional. And you might need to see me now, but your cancer response, your hepatitis response, you get a renal transplantation, and now you do very well for a considerable period of time. And then I might see you less. But then you come back because the disease and the suffering has come back. So please do not worry too much about the blurring of prognosis, because really defining that prognosis should not be your responsibility. You are person management. The disease management is for the oncologist who collaborates with you, the cardiologist, the gastroenterologist. They are the one. Of course, we are supposed to know a little bit, but I do it reading up to date or any book before I see the patient. Oh, well, okay, this one is doing like this and so on. But the responsibility to define that prognosis is for the disease management team. And so I would not worry too much about the fact that there is this blurriness. With regards to access, I think the colleague is completely correct. There is a much more difficult access to the non-cancer patients because our field started associated with cancer. So it's taking longer. There are already quite a few congestive heart failure programs and some lung programs. Are there any rationale in having specialized programs? No, of course not. It makes no sense. I mean, you and I can get tomorrow a cancer, or you and I can get tomorrow congestive heart failure, or you and I can get liver failure, and you and I continue being you and I. And our management is the management of the person. Yeah, there's a little bit of different half-life. You have renal failure, and there's a bit more dyspnea if you have CHF, and a little bit more pain if you have a solid tumor. But do you need to have special CHF, special renal, special liver palliative care? My proposal to you is it's about persons. It's not about diseases. The disease can be managed by the disease specialist. You are the person specialist. So you can deal with suffering in people with different diseases.
Thank you, Dr. Bruera. Well said, and indeed, so important. So we have one more question from Dr. Stanley McAdam from Bangalore. So Stan is asking about your experience when working in a joint team in the outpatients. What is your experience about that?
Yes, and I think this is an important point, because one of the points is you cannot have everybody see everybody all the time, but I think you need a very small core team that in our case is a specially trained nurse to do initial assessment, a physician trained in palliative care, and a counselor. And then we might need to bring occasionally to the team a physiotherapist and a chaplain, depending on the spiritual suffering and the functional needs of the patient, but not for all the cases and not all the time. And so I would say that you need to define the interdisciplinary team. Occasionally, a pharmacist is extremely helpful to address subcutaneous medications, combinations, and so on. So a pharmacist sometimes, in some of the cases, might be greatly useful. And occasionally a social worker might be necessary when resources and financial issues. So I would say, get a core of a small number of people. And very important, you need to work together. If I have somebody whose pain is 8, 8, 8, 8, and they say, Dr. Bruera, my pain is 8, my pain is 8, my pain is 8. And I know they're somatizing their suffering. They're somatizing because of mood disorder. I send them to a psychology clinic that is half a block away. They're seen by someone there. Then they get a phone call saying, Dr. Bruera, I would counsel your patient, but what I need you is to control their pain better, because then I can support them. My answer would be, well, do you think I would send them to you if I had not tried to control the pain with opioids and other medications, and what they're doing is expressing their suffering, their fear about death, their fear about isolation as a physical symptom? Now, if the person works in a solitude from me, the person does what they do, and I do what I do. If we work together, we end up understanding chemical coping. We understand disinhibition from delirium. We understand depression and anxiety causing somatization. We understand all those elements and we can work together. So to me, the challenge of interdisciplinary work is to work with a common language, with a common purpose, and it's hard to do in hospitals where the reportings are vertical. The social worker is a social worker, the psychologist works with psychology, the chaplain works with chaplaincy, and so on. So we try to create horizontal structures where we work together rather than vertical independent structures where they may not understand how we're trying to treat that patient.
Right.
Arun, can I ask one question, Arun? Dr.
Yes,
Bruera, I want to ask you, what is your protocol and policies for advising opioids through telemedicine?
Yes, and we do prescribe opioids via telemedicine. Now, we do monitor the patients who are at increased risk for utilization of opioids, and we monitor their so-called non-medical opioid use behaviors. When the patient develops no non-medical opioid use behaviors, develops no self-escalation of medication, does not go to several doctors trying to get medications, does not come saying that they lost the medication, etc., etc. When there are no behaviors that suggests that the patient is coping chemically, we maintain all the care by telemedicine. When there are those behaviors, now we say, I am so sorry, we can only see you in person. And you need to come, because sometimes we may need to do a urinary drug screen. Sometimes we might need to see you every week. I know we're so sorry because transportation is a problem. We're so sorry because of the time, but unfortunately, we cannot keep treating you by video at this point. At some point, it might be, but we're going to start seeing you in person every week. We might need to get a sample of your urine and see what's happening with the urine and so on. And then very slowly, you might regain every 2 weeks and then every 3 weeks, and then we might go back to video.
Thank you very much. So we have 2 more minutes, and I just want to give one more comment in the non-malignant integration with our own experience at AIMS. You are absolutely right that if we will not concentrate on prognostication and if we will concentrate only on the suffering and symptom management, I think it really works well. So it is important that we should concentrate on the patient suffering and symptom management rather than just barging on the prognostication. 1 more minute, and in 1 minute, I want to request Anjum, because all of us have one more opportunity to listen to Dr. Bruera in our international conference, annual conference of Iapc. And I request Anjum to please announce that Dr. Bruera is going to be there in your conference, our conference, and please announce yourself.
Thank you, ma'am. Dr. Bruera, excellent session. I learned so much. You've spoken so many important points integration, burnout, how your clerk was an important part of your team. I want to inform all the listeners that Dr. Bruera is part of our 29th International Conference of the IAPC, and you must attend to listen to him. And you also spoke about what's in a name. Incidentally, that is the topic of our debate this year. And you know, we have this very almost violent debate every year, which is started by Dr. Sushma. And this debate is, the topic for the debate this year is what's in a name? Do you think we should change the name of our specialty? So I'm inviting all of you, if you get another chance to listen to Dr. Bruera. Thank you again, sir. And a chance to participate in the debate, which he's already introduced us to. What is in a name? Thank you, sir. Thank you, ma'am.
Thank you.
So thank you, Dr. Bruera. It's 7:30. Thank you very much. We are really thankful, and we are really happy. Everyone, almost 140 people have joined in the morning. We have learned a lot. You are always an inspiration for all of us. And thank you, listeners. Thank you, audience, for joining early in the morning. Thank you, Arun, for managing the question and answer so briefly. Thank you, Nisha and Archana, for coordinating everything, activities so well. Thank you, Professor Bruera. We will be waiting for you to listen in annual conference. Thanks a lot. Thank you.
Thank you. Bye-bye.
Good
Have a
night.
great day.
Good night.